Hi, everyone. I'm Linda Laskowski-Jones. I am a member of the Blue Mountain Ski Patrol. And also am part of Bear Creek EMS. If you all just mute yourself, that'd be awesome. So as part of Bear Creek EMS, as Eric said, we put on these free educational sessions. If you're here in person, you can apply for continuing education credit through Pennsylvania, and Eric will take care of that. It is my pleasure tonight to introduce our speaker and just a little bit about Steve. I've gotten to know him through preparing for this presentation. Dr. Stephen Goldblatt is a cardiologist. He is in private practice. He's been in private practice for 25 years. He is now retired from office practice, but he is still engaged in hospital practice of cardiology in Connecticut. He is the medical advisor to Ski Sundown from 2020 to present. He's also the regional medical advisor for the National Ski Patrol, State of Connecticut Eastern Division, and that began in 2023. And he is a medical officer, Team CT1, Disaster Medical Assistance Team, and that's been 2023 to present as well. So I'm sure Steve has many other affiliations and other background and experience that he will share with you this evening. One of the things I wanted to make sure to point out for all of you, as Eric said, there are a lot of people from various professional paths. And so we are trying to provide a presentation that really will appeal to all and provide pearls of different types of
helicopters. Linda, you're muted.
Okay.
There you go.
Thank you. Was I muted the entire time?
You were just muted for the last 10 seconds.
Oh, okay. Thank you. All right. Since we have a broad range of people on our audience tonight, what I would recommend is that you come into this presentation realizing that some of what you will hear may be beyond your scope of practice, but then listen, learn, because chest pain is something that anyone can experience. A neighbor, the more you learn about what it takes to actually not only care for the patient in the pre-hospital setting, but also the path beyond that is very interesting, I think, to everyone in healthcare, and certainly it can teach you a lot. Dr. Goldblatt's been in practice for a long time, and I think he has some very, very interesting pearls that will benefit all of us. So without further ado, Steve, please take it away.
Here we go. So thank you, Linda and Eric, for providing me this opportunity. I look forward to sharing some information with all of you. And just a brief synopsis. When I started in ski patrol, it was a whole new world for me. I was in hospital practice, private practice, and one of the things I did when I was teaching OEC, trainees, is when I started, I said, okay, one of you sit down in a chair. I threw on my lab jacket and I said, here I am in a nice, well-lit room. There's a monitor, and you've come in with chest pain, and I say, hello, I'm Dr. Goldblatt. I've had a chance to review your records. I've got your EKG in front of me, and we've just finished the exam, and I can tell you you're not having a heart attack. And then I walk out, come back in, and I've got a jacket, a backpack, I've got heavy ski boots, and I'm stomping in, and I say, okay, now it's 20 degrees, lighting is poor, and I say, how are you doing? And you're not really able to talk very well. And I say, okay, can you tell me anything? Because I have no medical records. I can't really see you. My pen's not working, so I can't take notes. And so it really lets people know that I get it, that first responders are a whole different world. And I've really started to enjoy being a first responder. because you're out there with the patient. I'm not the person who gets the filtered story. I'm there seeing the story. And so the title is my way of blending my experience as a cardiologist with what would be kind of the OEC training, with sample and then describing pain using the OPQRST format. So without further ado, let's jump in a little bit, and I'm going to try and take it slow. Linda will provide some support if there's any hiccups, and Larry is also there to kind of moderate questions. So just a couple of things to start. First of all, you guys are great. I love working with you. There's probably a few people on this program who are from Ski Sundown, and a great group of people, but we all share the same mission, which is service and service to the public good, keeping people safe, and just being the heroes of the roadside, of the ambulance, of the ski slope. And I appreciate and love working with you guys. So a couple of disclaimers. We're not trying to turn you into experts. This is really for your education. If you are not a medical professional, this is not going to certify you to be a medical professional. So if you encounter someone who is in trouble, pick up the phone, call 911. Just, I hope you enjoy this, but once again, remember, this is education. Maybe it'll be a little fun. So the other thing is that advice from me is that chest pain is a tricky subject. And I don't have x-ray goggles, I mean, x-ray glasses. If somebody's telling me they have chest pain and I'm on the street or I'm in the bottom shack, what do I do? Well, I'm going to call 911 because I don't know what's going on, and it could be a heart attack. It could be anything. But if you have somebody with chest pain, don't assume that just because the information I gave you might help you get some clues. The right thing to do is call 911 or call a medical professional, and get some help. So here is a good start for our lecture and chest pain assessment. And here you have two people are experiencing chest pain. And I'm aware that there's 300 people here, so these are kind of going to be rhetorical questions, but the bottom line is, okay, which one of these is cardiac? You know, is it definitely cardiac? Can it be something else? So diagnosis is a little bit of science and a little bit of art. The science is knowing the questions to ask, knowing the algorithms, but then the art of it is learning how to get more information, learning how to use your intuition, or learning how to use my intuition and experience to kind of put together the picture. And that picture helps steer me in which way I want to pursue the answer. So this is really, there are lots of ways to do chest pain assessment, but I'm giving you my method of chest pain assessment. So getting the story and arriving at the diagnosis requires being kind of open-minded, considering all possibilities. Now, I will preface that today we're going to be focusing on the chest pains of coronary artery disease. But some of what I am going to present is what kind of questions and what kind of things do I do to either include or exclude other possibilities? So the first thing is when you see a patient, you don't want to, have a pre-planned image of what they have, and we call it tunnel vision, meaning that, all right, I've decided this person is having a cardiac event, or I've decided this person is having a gastric event, and you eliminate all possibilities. So that's why I am suggesting a systematic approach to help you include as much information as possible. And because you're EMS and first responders, you're trying to come up with a efficient, time efficient way to assess people. But as we say, slow is fast. Getting the information initially, getting complete information enables you to be efficient and move the process along quickly. Your job is, my job, and I'm not saying your job, but my job is to make an assessment. And particularly if I'm a first responder, it's how do I get this information in an efficient manner? And the sample and the OPQRST are the methods that I'm sharing with you guys tonight. So my suggested systematic approach, first thing I want to emphasize that tonight we're talking about non-traumatic medical assessments of chest pain. This is chest pain where something is not sticking out of the chest. They haven't collided with a tree. They haven't collided with somebody else. So we're talking about medical causes of chest pain. And I've kind of given you the preview that this is going to be more directly cardiac. At the next lecture, if we have the opportunity, I'm going to talk about other kinds of chest pain that are not the classic cardiac symptoms. So we have the ABCs, airway, breathing, and circulation. In order to do an evaluation and ask patient questions, the ABCs have to be intact. So we're going to skip past that. So the initial assessments involve sample and OPQRST. And following that, we do a focused physical assessment, and I will get into that. And then I want to get into a couple of things. One is, what are the approved medications and protocols that you can do as a basic first responder and as an OEC technician? But I also want to get into a little bit of the next level of assessment, which is pre-hospital advanced assessment, and then a little bit of what would happen in the hospital, because I just wanted to go into a couple levels. Linda thinks it's a good idea, and so did Eric. So let's jump into a little bit of this. Just a couple of anatomic terms. Probably many of you know these, and I'm not necessarily going to be using these, but just to make you a little bit more sophisticated with some of the terms that people roll around. Anterior means the front of the body. Posterior means the back of the body. Medial means toward the midline, and lateral means away from the midline. A lot of times we talk about people having mid-sternal chest pain, and that's chest pain in the center of the chest. But then there's also substernal chest pain or retrosternal chest pain. And this is like, I feel like this isn't at the breastbone, but it's kind of like deep. It's deep in there below the breastbone. So we may use substernal or retrosternal chest discomfort. Then we have another place where you'll see a lot of discomfort is what we call the mid-epigastric region. And this is kind of that area that is between the belly button and your xiphoid process. If you were to draw like an oval there, people put their hand on their breadbasket, as we call it, or solar plexus. That would describe what the mid-epigastric region is. Precordial is a good one, because people may, it would be like you put your hand across your chest. It's basically the right or left side, and it's pretty much covering the entire side of the chest. So if we describe someone as having left-sided precordial chest pain, it's the entire chest. Um, and then another one is infra. Infra means between. No, actually, it's infra is below. So it's below the shoulder blades. Inter is between the shoulder blades. So it's just a little bit of some anatomy, some anatomic terms. Now, common patterns of chest pain. The red areas are where people report having chest pain. So upper chest, but upper chest and the neck goes to the arms, goes to the axilla, the underarms, and it can also be in the back, in the mid back. Now, these are all possible distributions of chest pain due to cardiac reasons. But the challenge is that this can also be chest pain from non-cardiac regions. So that's why we investigate chest pain beyond just where it's located. And because you can get into trouble and say, oh, mid-sternal chest pain. Okay, it's the heart. It's into the shoulders. Oh, it's probably arthritis in the neck. So what I'm saying here is the chest pain can be in multiple places, but just because it's in a certain location doesn't give you your diagnosis. So the OPQRST helps you be curious as to possibilities of what it could be. And what I'm going to tell you is a little bit of what in the OPQRST kind of points me to a truly cardiac diagnosis, because there are other diagnoses. And if you say no to some of these questions, then I say, okay, I'm eliminating that as a possibility. Everybody, Linda's following this? Everybody following this? Okay. She's giving me a thumbs up. Okay, so O is for onset. And generally, onset, we start the day of the onset of symptoms. When did it start? Was the patient asleep or awake? Did it wake them up from sleep? Is it related to mealtime? Is it before, during, or after eating a meal? Is it during activity, or is it after activity? Or is it no relation to activity? Is it in cold weather or warm weather? Was it a gradual onset, crescendo, as I might call it, or was it sudden? And so these are all patterns of onset. And you can get, with true cardiac chest pain, you can get a lot of these. And it's not, and we're going to talk about not just heart attacks, but other cardiac causes of chest discomfort that have specific patterns of onset that are in here that you wouldn't have in someone who's having a true acute cardiac event. So P is for provocation and palliation. So one of the ones that I ask initially is if they're experiencing chest pain, does the chest pain change with respiration? Does it increase when you take a deep breath? So I have them take a couple of deep breaths and I say, what is that doing to the pain? And some people say, ow, it really hurts when I take a deep breath, and it hurts here, and they're pointing to one spot, maybe in the left side of their chest, maybe their ribs. And then there's the non-pleuritic, meaning that no change, that it's just sitting there. And between you and me, the pleuritic is less concerning to me. Someone who has chest pain that's changing with inspiration generally has something along the lines of a musculoskeletal pain, or I put there pleurisy. And pleurisy used to be an old term for when people had pneumonia and it would irritate the linings of the lungs. It would catch. So it'd be very sore. Another one is changing with position, and changing with lying down or sitting up. Generally, if it changes with position, once again, somewhat reassuring to me, but it points to other diagnoses. So each of these, it kind of reassures me, but then it points me in the direction of another diagnosis. Obviously, with change with movement, twisting, bending, straightening up, stretching, if it changes, maybe steers me away from a true cardiac diagnosis, but is it musculoskeletal? Is it something else? So these are some of the ways that I get more information. And then obviously changing with meals, is it before meal? Is it after a meal? Kind of points you in another direction. So this is kind of detective work. So, this is, me sitting across from them and putting a light on them and giving them the pressure treatment. No, only kidding. So Q, if I can make it happen. Okay. So Q is quality. Interesting. Sometimes people will give you an image, or they'll say, well, it's not really a pain. When I say pain, pain is actually could be anything. It could be discomfort. And somebody would say, well, if I could just burp, I'd feel a whole lot better. So that tells you, well, there's a fullness somewhere, maybe in their upper abdomen, in their chest, and it's just not going away. Or maybe it is going away. And then some people say, oh, it's like a band around my chest. So other descriptions would be a sharp or stabbing pain, or a dull pain, pressure, crushing, burning, tingling. And this one really makes me worry. And this I imagine we'll discuss the next time, is tearing. Someone who it was a tearing pain. It started in my chest and went through to my back. And I'm not going to get through that here, but that's kind of a very unique, severe pain that when I hear that gets my attention, and without even thinking about it, I would say, okay, get me the ambulance now. So R is radiation. You go from the original position of where the discomfort is, whether it's in the center of your chest or it's in your arms. And sometimes it could originate in one spot and then say, okay, it started here, but then it started my arms, but then it went up into my neck or into my jaw. And then, so you want to find out where it is. Is it in the arms or the shoulders? Is it on one side or the other? Does it go around to the back, or does it go through to the back? Does it go from the back to the front? And based upon the patterns, some of these clearly point me definitely to cardiac, but some of them can be other causes. And I press a little bit more about, once again, does it change with movement? Did it change with meals? But there are, just because someone says it's radiating to the left arm, it's radiating to the jaw, it doesn't mean it's cardiac. Lots of other things can also radiate to different places other than just, somewhere in the chest or in the stomach. And then S is severity. 0 being I'm having no discomfort, and 10 is the worst discomfort you've ever had in your life. Recognizing that severity changes. It can change over time. It could have started out as a 1, barely noticeable, and then over the next hour intensified to a 10. Or it started out as a 10 and now it's like a 2. Once again, it could be a 3, when you're lying, 3 when you're sitting up, and it becomes an 8 when you lie down. And once again, if they say, well, it's not really a pain, it's a discomfort, and it's hard to quantify. Well, is it a significant discomfort? Is it a discomfort that impairs your breathing? Are they sitting there unable to move because they're so uncomfortable? So sometimes you have to look at the nonverbal cues. You have to look at what they look like. And are they having a difficult time moving? Can they not get comfortable? These are all things that I would look at. And then S also stands for I put in associated symptoms because there are some very characteristic symptoms that you would have, particularly if someone is having a cardiac event. Um, Nausea is one that I see a lot. Sweating. One that I see that makes me worry is something called diaphoresis. And for those who don't know what that is, if you've ever had someone who's really feeling nauseous and they break out in that cold sweat, they're soaked, and their clothes are wet, they're dripping, but they say I feel cold and clammy. That's a what we call diaphoresis, and diaphoresis is really kind of the same reflex that causes nausea. It's a profound vagal reaction. And you might see that in somebody and then they faint because the vagal activation, the vagal nervous system, can cause slowing of the heart and can cause you to pass out. And so diaphoresis is part of that. And then dizziness, because if they have these vagal reactions, it slows the heart, can lower the blood pressure, so it can make them dizzy as well. And then T is for timing. And once again, you may be summarizing things from from your previous OPQRST, but repeating a story is always helpful because they may recall other facts that the first time they say, oh yeah, well, it wasn't just after a meal. It was, I had gone out for a walk and it really seemed to get worse when I went out for that walk. And so, things like how long has it been going on since its onset? Has it gone away and then come back? Is it constant? Is it intermittent? Is it changing over time? So timing is not just what's it doing now. It's what happened today. And sometimes a classic story is, it was I was having it was coming and going, and over the past hour, it hasn't gone away, and it's been constant. And so that will worry me because it's not going away. It's constant. That would worry me. And so
So one quick point that someone in the audience made that I think is important to pass along. Derek K said severity is relative to each person, or they need to ask a baseline question such as, what is the worst pain you've ever had? How does this compare? I just wanted to throw that out.
absolutely. And some pains, I've had people say, like a kidney stone, and actually, the one I mentioned, the tearing, they say it's a 12. I mean, but yes, 0 being you're not having pain. And thank you, Derek. Yes, it's the worst pain you've ever had. And as I said, sometimes it's hard to quantify because maybe you've never had discomfort, you've never had fullness. And sometimes it's just, is it a little lump in your stomach, or is it like somebody's just blowing up a balloon in your chest and you feel like it's just blowing out of your chest? So these are quantifying is challenging. So then T is for treatments. Have they done anything to try and alleviate the pain? Sometimes, putting a cold or warm compress. Sometimes, have you taken antacids? Have you taken nonsteroidals, which if you're having a certain kind of pain, wouldn't make me happy because I'm not really thrilled with the way that might interact with an aspirin. And have you tried nitroglycerin? And Linda always corrects me. I'm using the British version where it ends with an E, and in the American version, nitroglycerin ends with an N. And then also sometimes people, it hurts to take a deep breath, and so they use their inhaler. So I ask if have any of these alleviated the discomfort. And finally, another one, which is, and once again, those open, oh, sorry. Actually, maybe I didn't put it in here. Let me see if I have to find it. Okay. U is understanding and impact. It is, what do you think is going on? What do you think is causing this? And so you're going to say, all right. And they say, I think it's this. And I say, well, why? They said, well, I've had stomach pain before, and this is nothing like that. Or this
Yeah.
happened. This
Yeah.
happened at a time when I was sleeping, and any other time I've had discomfort, it's only when I've been exercising. So, and another thing is, have you had similar symptoms in the past? And what were they? Um, One of the things that's helpful, I won't say it's helpful, but if someone has had a heart attack or if someone has had heart pain, I ask, well, is this the same? And they said, no, this is completely different. A lot of times I'll breathe a sigh of relief because generally cardiac pain isn't two totally different pains. Someone's heart pain is their heart pain. Your heart pain, when you had your heart attack, went into both your arms, but there was nothing in the center of your chest. Now you're having something in the center of your chest and it hurts to take a deep breath. That usually is something that I breathe a sigh of relief. Now, I'm not trying to tell you what to think. What I'm trying to help you get is it's what I love about what I do is it's detective work. You want to gain information, and the more information you have, the more you can put together your algorithm and your bigger story. So let me switch on here. So the next piece that's helpful is your sample. And there's specific things that I look for in the sample. I mean, I'm not, this is not, we're not trying to get their trauma. We're not trying to get what happened to them. This is getting the medical history. So the signs and symptoms is the OPQRST evaluation. Under allergies, the big one is aspirin. That's very important because that's going to be part of your treatment. And then medications and past medical history. The medications that I'm looking for are things that are taken for risk factors, which are below, and I will mention those. But another one that's tricky is people say, oh, I take supplements and I take vitamins. And some of these are cardioactive. I take Hawthorne. Hawthorne is cardioactive. Or maybe they think that Viagra is a supplement and it's not really a medication. So, and one of the big ones is erectile dysfunction medications. And people also take them for pulmonary hypertension. So there is overlap there. So you really want to know about those. And I'll explain that later on. So, and I will also ask, so once again, I'm trying to come to a diagnosis. I'm trying to narrow the realms of possibility. So there's the major risk factors. Excuse me, I just have to kind of see if I can move this because there we go. So the major risk factors, diabetes, and we're talking about diabetes type 1, which is insulin requiring, and diabetes type 2, which generally people take pills, although sometimes they get converted to to insulin. And even if they say, well, I got borderline diabetes and I control with diet, that's still a risk factor. High cholesterol, you know, you've been told you have high cholesterol. Are you on any medications for it? And a lot of people would say, no, I'm afraid of taking medication. And I kind of look at them and say, um, I have my opinion on that. We'll discuss it. And then we have people who are smoking. And I say, are you a smoker? He says, oh, no, 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 I quit. Oh, you quit. Good. When did you quit? Last week. Okay. Up until that point, I was smoking 2 packs a day for 30 years. And then family history. This is one which people don't think to ask. And even I had to Google the right ages for this. So family history is first line relatives. And if it's a man, it's a brother or father who had a cardiac event, heart attack or stroke under the age of 65. I'm sorry, that should be under the age of 55. When I was editing with Linda, she was telling me edit, and I don't know if I can edit this now, but no, I'm not going to. But it's 55, and then mother or sister under age 65 if they've had a heart attack, stroke, or cardiac event. And last one is hypertension. Whether or not they were on medication, you just basically ask, have they had these? And then last eaten, and then you can ask about, once again, relationship to meals, and did this come on before, after, or during? And then events leading up to this. I didn't put that in here, but you can say, can you give me anything more about this? And they'd say, well, you know what? It's been coming and going for the past month. And over the past week, it's been, instead of coming on once or twice a week, it was coming on 3 or 4 times this past week. And then today, and it would last 5 to 10 minutes. And today it's been a half hour and it's not going away. So that is what we call crescendo symptoms. They're increasing in frequency. So that kind of worries me. So that's a bit of what I would get when I'm trying to get this story. So then I just want to say that there are multiple causes for chest pain, and today we're going to focus on cardiac, but there's respiratory causes, there's musculoskeletal causes, there's gastrointestinal causes, and there are actually cardiac causes that I'm not going to get into tonight, because we're trying to focus on the ones caused by coronary artery disease tonight. But at the next lecture, I hope to be able to get into those as well. So when we do a focused assessment, I'm not talking about doing a complete physical exam here. We're not doing reflexes. We're not doing complete evaluation, because time is of the essence in a lot of these people. So I'm just giving you some of the things that I would try to do in a focus evaluation. The first thing is, what do you see when you walk into the patrol shack? Or what do you see when someone's in the lodge and they say they're having chest discomfort? So you look at the patient, you're getting that visual picture. Are they sitting there having a drink and eating, saying, oh, I'm having some chest pain. Yeah, it's right here. Yeah, yeah, okay. I might have a different impression than someone who is sweating and just looking at me with fear, and you just say something's wrong. They're scared. Do they look sick? Are they pale? Are they ashen? Are they diaphoretic? Are they covered in sweat? So you can kind of start doing a little triage of one of the key things that a doctor has to learn is the patient sick or not sick? Does this patient can this patient stay at home when they call you or does this patient need to go to the emergency room? So you start to develop a little bit of that intuition, and I'm sure all of my EMT colleagues, you when you walk into the house and you're taking that history, you look at them, it's just you do it, repetition, and you just get that third, fourth, and fifth sense. So one of them, another one is, can they get into a comfortable position, or are they moving all over the place? Can they just say, ouch, I just can't seem to get in a comfortable position? Can they move without pain? And if they say, if they're taking shallow breaths, I say, well, if I take a deep breath, it really hurts. Or, you try and sit them up and they're like grimacing, so that kind of pushes you into a different direction than I would normally think about being, the heart. And then also, what is their position of comfort? When they are sitting there, are they sitting there leaned over, trying to, with their arms like on a table? We call it like a tripod position. Are they struggling to breathe? And then, so you form this kind of picture, and then you go to your vital signs. And obviously, you're looking to see if they are stable or unstable vital signs. And that would triage you immediately into getting a 911. No matter what the cause is, if their vital signs are unstable, their blood pressure is 80, their pulse is either 40 or 160. Regardless of what the cause is, that person needs to go now. You're not going to wait there and try and figure it out. As we say, you don't play. It's like you don't play on the mountain. You get them down. You transport them. We check blood pressure in a true chest pain evaluation. You check it in both arms. You want to make sure it's equal. And I will say that I'm not trying to scare you, but it could point to a serious condition called an aortic dissection. I'm not going to get into that today, but you really want to check the blood pressure in both arms if they're having a lot of pain. And that would be one of those, get them down the mountain and get them down the mountain. If they're having pain and the blood pressure is unequal in both arms, get them to the hospital. And then obviously we're going to check the pulse. We're going to check the heart rate, respiratory rate. And as I said, if any of these are seriously off, then it's time to get them in an ambulance, get them out of your patrol room, get them down the mountain. EMTs, basics and advanced, know you got this. You're packaging them and getting them to the hospital as quickly as possible. So, and then I also, and I mentioned this a little bit, I do these to kind of maybe reassure me or steer me in. It helps to exclude certain things or include certain things. So I have the patient take those deep breaths while they're experiencing the chest pain. I have them lie down and then sit up. I have them turn from side to side. So these maneuvers might help narrow the possible causes of the chest pain. And some of these we'll get into the next time we talk, unless for some miracle reason, and I don't think we're going to have that miracle reason, but maybe we will. We have some time to get into that. So another thing that patients will do is they will describe their pain non-verbally. And when you ask them, my wife loves to talk with her hands. And sometimes I have to get out of the way because she loves to spread her arms out when she's telling a story. And if I'm too close, I get a concussion. But so when you ask the person to describe the pain, they say, well, it's right here. Well, if they're giving you a closed fist, they're telling you something about the pain. They're telling you it's heavy, it's tight. It's uncomfortable, particularly if they're bending over and this discomfort is, they're crunching around this discomfort. And then another time, someone will have an open hand that's going across the chest. It's like, oh, it's right here. So you know that it's covering the chest and it's covering the precordium. So this is, the precordium. It could be on this side, it could be on this side, but it's telling you it's a widespread pain. And then they might say, well, I say, oh, it's in the arm, and they're saying it's the entire arm. Now, one that's very reassuring is when somebody says, well, it's right here. It's just in one spot. And they're sitting there, they're comfortable. They say, it's just in one spot. Whew. I'm just going to tell you that that is generally a very reassuring description. So this is another way to look at the patient and get a more full story. So how are we doing, Linda?
We're doing well. I'm just going to say we're going to take a break at 8:30, and then we'll
Okay.
be back after that. But we still have a few more minutes, so please continue.
Okay.
Yep.
So this is we're going to start doing a little bit of taking off from the runway and doing some learning. And for those of you who know this, I may be a review. And for those of you who have never seen this, I hope this is a nice little introduction. So I'm sure all of you have heard what about an electrocardiogram. Maybe many of you are very experienced in this, but some of you have never seen one. So an electrocardiogram is something where we are looking at electrical activity from 12 different points on the heart. And each of those little patches is recording electricity from a given point. And each of these points will correspond to an area of the heart. So you can say, oh, okay, I see an abnormality here. This is involving a certain area of the heart. The important thing about this is that the major portion of the heart that this is focusing on is the main pumping chamber of the heart, the left ventricle. So this is really providing you vital information about the circulation to the pumping of the heart. So a normal EKG, which is what this is, tells you so far so good. Does it mean that someone having a problem, having a normal EKG completely eliminates the possibility? No. But if you're trying to decide, particularly the paramedics or the EMTs who run the EKG and send it to medical control, a lot of times you can say, all right, this is not serious. But remember, part of it is if this person is diaphoretic and their blood pressure is 80/50, and you're not going to say, oh, normal EKG. I'll see you later. Okay. And so the normal EKG is a tool, but it's not the answer. It's a tool. So when we look at the EKG, each of these recordings has some spikes and domes. Okay, so this is once again the same thing. And so an individual electrical signal, see, each of these deflections is a cardiac electrical impulse. So if we focus on the cardiac electrical impulse, we have a P wave, we call a QRS, which is the spike, and then we have a dome after that. So we have dome, spike, dome. So just briefly, the P wave is when the upper chambers are being squeezed to push blood into the lower chambers. The QRS is when the lower chambers are being activated and they squeeze the blood out. And then the T wave is when the electrical equilibrium is restored and everything goes back to a resting state. So there is something there kind of on the right-hand side, which is called the ST segment. Now, you see that there's a basic line that is kind of going through that's a flat line that everything deflects from. So we call that the baseline. And if you look at that ST segment, the purple segment, you can see that that's at the same level as as the other lines. So we call that isoelectric. We call that no ST segment deviation. So that's pretty damn important for the next few slides. So once again, here's that ST segment again, kind of at the same line as the baseline. So the baseline is where the primary, where your heart is electrically neutral, where it's electrically at rest. It's not firing off impulses. And electricity is what makes the heart pump, meaning that without electricity, the heart doesn't pump. And it has to be organized electricity. It has to be sequential. If it's not sequential and it's not organized, that's where you have life-threatening arrhythmias. So, and the sequence is very important. Obviously, people who have taken ACLS or EKG training know that if you're missing one of these, you have a problem. And particularly if the rate of the heart is too fast or too slow. So when you have changes in the ST segments, this is the heart saying, I'm in distress. Something's not right. So the first one is a normal ST segment. This is, the heart's okay. Everything seems to be okay. The next one is ST segment elevation. It's above the level. And then the J point is the point where you go from having that narrow upslope to where it becomes the curve of the ST segment. So the J point is above the baseline in one, and it's below the baseline in ST segment depression. Is that okay? I mean, Linda and Larry are I can't see a 300 people nod, but obviously, if we have more questions about this, I'm happy to try and address these. Oh, okay. No, I don't want that one. All right. Do I? All right, just give me a second here. All right. So we're going to go into one of these scenarios. And so do we want to take a break now because I'll present the scenarios, or do you want me to let people think about it and then we'll go dig a little bit deeper after that?
Well, the other thing I thought about was what about going back to your ST segment and just saying what that means, unless you're waiting to surprise people. But so that.
Oh, no. Okay.
Yeah,
So
go ahead.
well, I'm going to get into that later on. But the ST segments indicate, particularly the ST elevation indicates that the heart circulation to a certain area of the heart has been completely stopped. The heart muscle needs a constant supply of blood and oxygen, and it needs adequate blood and oxygen in order to stay alive, in order to pump. If you completely block that circulation and there's no oxygen getting to the heart muscle, then you develop cell death, and we call that injury. And another name is infarction. So ST elevation means infarction. It means there's heart muscle dying. That is, the heart is in real distress. ST segment depression is another kind of cardiac muscle distress, but this is the heart is not getting enough blood, but you're not getting imminent damage. It just says, hey, you know what? It's like I'm short of breath. I'm not getting enough oxygen. I'm breathing heavy here. I'm short of breath. And even the heart muscle is saying, I'm in distress. But it doesn't necessarily mean damage. In some cases, if it's bad enough and if the distress is bad enough, you can get some damage. So the terms we use are ST elevation myocardial infarction. The other name for that is STEMI, and I'm going to get that into that a little bit later on. And then if it's non-ST elevation MI and it's not necessarily damage, is NSTEMI. So if people who know ACLS, we have the ACS protocol, and then there is the decision point of STEMI versus NSTEMI. And where that ambulance is going to go is based very strongly on the EKG. And for the first responders, particularly the ones who have this capability, the time to getting that EKG is within 10 minutes of what we call first medical contact. Or first medical contact can be the arrival of a paramedic, or it can be arrival in the hospital. So that cutoff is we want it in 10 minutes because then treatment really starts. Then we know what's going on. And that's what the next portion of this lecture is going to be about.
So why don't we take 10 minutes? Eric, is that okay?
Yep, that works for me. So let's resume this it's 8:28, so we'll come back at 3:38 and we'll get started. If you haven't already, please complete the attendance log. I will share a QR code and I'll put the link back in the chat. All right, see you in a bit.
Okay. How are we doing, Linda?
We're doing great.
Great.
Hold on. I'm still recording.
Yeah.
All right, that's all you, Steve. Oh,
Thank you.
Linda, do you want to?
Yeah, I just want to
Go
jump in.
first.
Yeah, real quick. I was remiss not to introduce the man who's sitting next to me, who is Larry Jones, and he's also monitoring the chat. So we will try to respond to any questions that come in. And for the people who are interested in the YouTube recording, it will be on Bear Creek, the Bear Creek YouTube channel. So, and then if also you could put in the chat where you're from, it would just be interesting since we've got a lot of people here from all over the country, just to say maybe your name and the city that you live in. And with that, I'll hand it back over to Steve. Thank you.
I just want to tell you guys, thank you. This is fun for me. I learned a lot putting this lecture together. I have never put a lecture together of this length, and I really appreciate Linda and Eric giving me some support, and hopefully to do some more of this in the future. So this portion is going to be a little bit more about the physiology of the heart and maybe help you understand why we do what we do, not only in the hospital, but why you do what you do as first responders. So this first scenario is a 48-year-old gentleman. His reporting chest pressure, not having it now, but he says, "Hey, doc," or "Hey, patroller, today I was walking up to the to the chairlift, and I kind of got some chest tightness, and I've gotten it before when maybe I've been climbing the stairs, but when I walk on level ground, I'm fine. I walk and I'm not having any symptoms. And so I just don't know what's going on. Now, obviously, I'm not expecting you guys to diagnose this, but this is just put yourself in my position and let's talk about what is going on. So the P of this is it gets worse with exertion. And exertion means anything worse, anything more than just walking on level ground, meaning it comes when I try and walk up 2 flights of stairs, when I try and jog, when I am trying to, do raking on yard work outside. And then if I stop, for a couple minutes, it gets better. The quality, it's like a pressure in the center of the chest. It can be associated with a little shortness of breath. Sometimes if I push myself, it will go up into the throat. Almost feel like I have a choking sensation, and then I really have to stop because I know I've really pushed myself too hard. And sometimes instead of taking 2 minutes, it might take 5 minutes until it eases off. And then the intensity, if I'm not pushing it, maybe a 1, but if I really push it, yeah, it can go fairly severe. I mean, it's not the worst pain I've ever had because I wouldn't push it to the worst pain I ever had, but I'd say maybe about a 6. And the timing is it's clearly related to anything more than low-level exertion. So it has a pattern. It has symptoms of chest discomfort. And I'm not trying to cheat, but I am saying that this is, a cardiac diagnosis, because for this part of the lecture, I'm trying to teach a little bit about cardiac physiology. So let's just go through a sample. So they're allergic to betadine. They're on Tums because they get this occasional stomach discomfort, and they're also on Prilosec, and they're on a water pill called HCTZ because they have high blood pressure. They have a history of ulcers. They have a history of high blood pressure, and they got a history of, well, my cholesterol is borderline, and they're keeping an eye on it. He last ate breakfast 2 hours ago, and sometimes if he has a big breakfast, if he goes out and goes for a walk, he might get the symptoms, a little bit more easily. And then he says, you know what, it comes on every day or anytime I'm walking uphill, going upstairs, or doing anything more than quote unquote mild exertion. So what is this entity called? So it's called stable angina, meaning stable, meaning that it is a pattern that has remained the same for a period of time. It's predictable, and it has not been increasing in severity for a given period of time. And angina literally means choking. It's not agita, which is, what your kids can give you. But angina literally means choking, a tightness in the chest. So that's generally the classic symptoms that people report. So the question is, all right, why are people having this? What is the cause of angina? And a little bit of this is going to be the principle of what we call supply versus demand. And that would explain, why does it happen with exertion and why did it get better with rest? So we're going to go into a little bit of the physiology here, and hopefully I'll be able to help you understand a little bit of this.
Steve,
Yes.
there were 2 comments. One was a question regarding whether or not the person was overweight. And secondly, a person pointed out that if the chest pain is happening daily or regularly, what is it that brought the patient to a care provider today? What was different about it?
Those are great questions. Certainly, obesity not only is a risk factor, but it also means that they have to work harder to exert themselves. It's relatively greater exertion. And then why are they here? Well, you know what? That's a question, an open-ended question that you would ask when somebody is in your office. The point here is that it's a stable pattern. and that it's just sometimes it's just, you know what, this has been bugging me. It's been going on for weeks. And I just decided it's time to do something about it. Now, somebody could say, I used to get this a couple of times a week and now I'm getting it every day. That's unstable angina. That's someone where the symptoms are increasing. That's slightly different. And I want to stay with the stable angina to explain some of the principles of it. Does that work? Okay. But I appreciate the questions, and it helps everybody to ask the questions. So, first of all, the heart muscle, as I said, depends upon a constant supply of blood to the heart muscle. A constant supply of blood because the oxygen is necessary for the muscle to function. So, oxygen utilization is what the muscle is doing, and what the arteries, these coronary arteries, are doing is supplying the blood to the heart muscle. So when we're born, and hopefully for many of us through life, we have a clear channel for the coronary artery. It's what supplies the heart muscle with blood. But in many of us, plaque forms, and plaque starts as an imperfection on the inner lining of the artery of the heart. And over time, it can accumulate cholesterol, and it will grow. And over time, it will grow and narrow what we call the lumen, or the channel. So that means that you have a limited amount of blood flow that can go through that artery. Now, usually when it's about 20, 30% blocked, generally it's not a problem. But we generally say when the artery becomes about 70% blocked, you're going to start seeing symptoms. Hello. And so let me flip down to the next one. So what this means is that we have an oxygen demand, which is the heart muscle, which requires a certain amount of blood, and it requires a certain amount of oxygen delivery per minute. Now, when on the right-hand side, when your oxygen demand and your oxygen supply are in mismatch, and I know it seems like oxygen supply is heavier and oxygen demand is lighter, but really what it's saying is that oxygen demand has gone up and oxygen supply has gone down. We have a mismatch, meaning that there's more need for oxygen than can be provided because the coronary artery is blocked, so it can't increase the delivery. We call that ischemia, and that's where the blood supply is inadequate, and that's when the heart muscle starts to go in distress. And angina is the symptoms that you get due to ischemia, and ischemia is the condition where oxygen supply is less than the demand. And demand is dictated by the oxygen utilization by the heart muscle. So things that increase demand are exercise. You're raising your heart rate. You're raising your metabolism. When somebody has a fever, when somebody is emotional or excited, or when somebody is doing something more than just walking. Walking is low-level activity, climbing stairs, going up an incline. You're increasing the demand, and you've got a fixed supply because it's like a hose where it's kinked, and you can only get the water to go out just so quickly. And so when you've hit that limit where you have ischemia, that's when you develop the symptoms of angina or angina. So one of the things that we do, actually, all right, is we do what's called a stress test. If we're trying to develop, we're trying to assess how bad the blockage is. If someone can walk on level ground, but anything more than that just makes them short of breath, they don't have a lot of leeway in their blood supply. And so we may think that those people have a significant blockage because their flow to the heart muscle is really limited. So what we do is we artificially increase the exertion on the heart, and that's called a stress test. So we're basically putting them on a treadmill, and we start off at very low levels of activity, and then we increase it every 3 minutes on a stress test. And so what we're trying to find is at what level of exertion does the heart muscle get undersupplied and go into distress. Now, one of the things that we talked about earlier on is the ST segments. So as we said, when ST segments are in neutral position, things are okay. If the ST goes up, we're dealing with damage. When ST segments go down, we're dealing with distress, but not necessarily damage. And so when we increase the activity of the increased distress and the energy utilization, we can measure in watts, which is the energy that is utilized per unit of minutes or hours. And so what we look for is there a change in that ST segment as we increase activity? And as you can see, going from left to right, when this person increased their activity, the ST segment went down, meaning that you created ischemia, blood flow lack, because you increased the demands of the heart muscle and the delivery was inadequate. So we infer that therefore there is a limitation of the blood supply. Now, another thing that we do, which is the next level, is this the picture on the on the right side of the screen. And this is what we call a nuclear stress test. And what we do here is we put a blood flow tracer into the body. And this can be picked up by radiation detectors, radiation cameras. And so wherever good blood flow is in the heart will show up as taking up radiation. So on the left side, called the rest, the normal pattern is the heart is kind of like a salami, and it's a half of a salami, so it's got an elliptical pattern. But if you cut it one way, it's round, and you cut it the other way, it looks like a horseshoe. So on the left side, you can see there's a nice round circle on the top and a pretty complete horseshoe on the bottom. And on the right side, you see that part of that circle is cut off. And then on the bottom, part of the horseshoe is cut off. And what that means is that during stress, those areas of the heart are not getting enough blood, and the heart muscle is not getting enough oxygen. So we can back infer what artery is blocked based upon the stress test. So these are some of the things that we do to assess when somebody is having angina. Now, the point of angina is it goes away and there is no damage that's associated with it. So those are important points to note when you talk about angina. And also, as I said, it's a predictable pattern. And Generally, it's caused when an obstruction gets to a certain level. And when the symptoms come on with less and less activity, we make the assumption that, okay, that plaque is growing and growing, but it grows slowly. And growing slowly is one thing, but then something can happen to that nice, stable plaque, and all of a sudden you get an obstruction that's severe. And that's what we call an acute coronary syndrome. Acute meaning it's happening right away. Coronary meaning it's the coronary artery, and syndrome is it's a pattern that we know about. So whoops. So let's go to the next scenario. So it's a 68-year-old gentleman, and although I talked about all the possible places where you can have chest discomfort, I'm going to give you a typical one here. So it's a 68-year-old male who presents with chest discomfort. It's mid-sternal. It started 2 hours ago and it hasn't let up. It's constant. It's unchanged with position, with breathing, with twisting. It's described as a pressure, not a pain. And a lot of times people say, I think it's just gas. I mean, it's something I ate, it's just gas. And that worries me more because they're trying to get around the fact that there's something really a problem. It's going to both arms and it's pretty severe. It's 8 out of 10. I said, oh, this hurts. I mean, it's really tight on the chest. It's not changing. And he was sitting on the couch and it came on. There's no warning. He hasn't done anything about it, but thank God he decided he needed to call 911 and get this checked out. So under sample, we have our S, which is the signs and symptoms. He's allergic to a blood pressure medication called lisinopril. It causes a rash. He's on blood pressure medicine. He's on antacid, but he said, I've been taking the antacid because lately I've been having a lot more of this gas. So I think maybe over the past month, and especially over the past week, I've had a lot of gas. So I've been taking this. So you can do the math on that. Maybe or maybe not. And under his past history, he has high blood pressure, he has high cholesterol, he's keeping an eye on it, and he quit smoking last year. He had dinner 3 hours ago and developed this about 1 hour later. So we talk about, once again, this person is having what is termed an acute coronary syndrome. I'm not going to get into the vital signs. I'm not going to get into the assessment. I'm going to skip that step and go into, let's talk about what is an acute coronary syndrome, also because I'm trying to get this done in a reasonable amount of time. So an acute coronary syndrome is not a gradual loss of blood supply. It's a sudden loss of blood supply to an area of the heart. And because it's sudden, it's like shutting the power off to something that can't run without it. And without that, the oxygen is removed from the heart muscle and the heart muscle starts to die. And so you're getting damage to the heart muscle. And that's what we term infarction. So on the left side, you can see that from 0 to 3, there is gradual accumulation of plaque as one gets older. And then what's happening in the last slide is you've gotten a narrowing, but all of a sudden that plaque, which was just cholesterol, cracks open. And when the plaque cracks open, it sets into motion. Oh, bye-bye, Monty. It sets into motion a blood clot cascade. And when that cascade happens, you get a clot. And that can either completely or almost completely um, block the supply to a certain area of the heart. And on the right-hand side, you see that blood clot blocking the lumen, the channel. And when you see that there's a certain artery and we have dying muscle, Linda wanted me to point out that that is the artery called the left anterior descending, also called the widowmaker, because it supplies 40% of the blood to the heart. So if you have an infarction that involves that entire, what we call distribution, you may not survive. Now, with technology the way it is now, people do so much better. But back when I started in practice, and really all you could do was give them oxygen and aspirin and nitroglycerin for their chest discomfort, the damage could be devastating. So here we have an EKG, and there are a number of leads here where if you look at your baseline and you look at those sharp spikes right next to them, you can see that there's an area well above that baseline. So this is a STEMI. This is what is a complete blockage, and this is an emergency. These people you've got to get them moving. You've got to get them in the ambulance and to the hospital. Not to say that the other version, an NSTEMI, is equally urgent if that person is experiencing chest discomfort, if their vital signs, if their blood pressure is low, if their heart rate is extremely low or extremely fast, they also are urgent, but their management is slightly different. So a STEMI implies cell death, an NSTEMI implies heart muscle that's in distress, but maybe not quite as bad. But because we say a myocardial infarction, it could mean that there's cell death. But the analogy I use is, if you think about the heart muscle, the thickness of the heart muscle like a hamburger, a STEMI makes it well done. It penetrates the entire thickness of the heart muscle. An NSTEMI is rare to medium, meaning it partially damages the heart, but it doesn't completely damage all of the heart muscle.
Steve, there was a question about a coronary artery dissection.
Yes.
Yes, and just what about that in terms of your considerations in this situation?
Once again, coronary artery dissections, which you can see a lot, and actually it happens in pregnant women. It's one of those situations where in pregnancy, a lot of the elastic tissue in the body becomes even more elastic and softer. A normal artery, the internal lining can tear and either partially or totally obstruct the blood supply to a coronary artery. The management of that depends upon the level of obstruction and how far that tear has extended. Sometimes we actually, I'm not the stent putter inner, but sometimes if it's a small dissection, they say, let's keep her on blood thinners and let's watch her progress. But sometimes if it's bad enough, they go in and they'll put a stent in. And if it's really bad, they may need to go in for bypass surgery. So good question. Scary situation, especially scary because it frequently occurs in young, healthy, pregnant women or immediately postpartum women. So I'm going to, let me see if I go to, so when we have someone who has a STEMI, we need to get that person to a hospital. And really what we want to be able to do is to get that person to a hospital where they can open up a completely blocked artery. So we have, and this is under the ACLS protocols, we have specific times that we want to meet, specific time deadlines. And this slide gives you the idea of the terminology. So the top is symptoms to balloon time. So that means from the very first, I'm having chest pain and 911 call, or actually before that, because some people will sit there and wait for 2 hours. And then they finally call to the point where they're in the heart catheterization lab and they've opened up that artery. That's what we call the symptoms to balloon time. But we also have what's called when the EMS arrives, and that's first medical contact to balloon time. And that's what we are trying to shoot to get under 90 minutes. Obviously, there's within 10 minutes, we want to get that electrocardiogram to determine if they're having a STEMI, because that decision point will tell them we have to go somewhere where they can open up the artery. And we call that a PCI center, percutaneous coronary intervention center. So that is where we direct them immediately to. Hopefully that can be within that needed time of getting them from the home to the heart, and then to the cath lab and open that artery within 90 minutes. That is the goal. And one of the other things is that generally we want them to have been having symptoms for less than 12 hours. After 12 hours, we think that the damage is done, and we generally, at that point, we do not rush them to the hospital to try and open the artery. And that's not always, but that is part of what you'll see in the ACLS guidelines. So just a look. I'm sorry. Linda, I lost you. You're muted.
No, I was going to say someone muted themselves, so that's fine. Please go on.
So this is just a more graphic of exactly what we said. Chest pain, and hopefully the patient calls 5 minutes after symptom onset. Well, okay, best case scenario. Dispatch 1 minute, EMS on scene within 8 minutes, and then they're getting that EKG. And while they're getting that EKG, they're doing their evaluation, they're asking the questions. I mean, a lot of things are happening at the same time. You're doing that assessment, you're doing the OPQRST, and you're doing that sample. And that's why having an efficient process, you don't miss things. You don't forget to ask about that allergy. You don't forget to ask about, did you take that erectile dysfunction drug? So that's why you want to have that protocol. And so then once you get the EKG, then you can make the decision as to where they go. The one on the bottom line here, I think, is if they're already in the hospital. If they're in the hospital, they say get them the EKG in less than 10 minutes if they come directly to the hospital, as opposed to coming from home, and then getting them into the cath lab and getting that artery open. So you can see that at the bottom it says patient self-transport, hospital door to device, and I don't have the time there. Less than 90 minutes as well. Although I think 60 minutes should be more what it should be if they've walked in the door. Okay, and so, all right, so let's talk about aspirin versus nitroglycerin. There was a little bit of a discussion about which one you give first. And if you think about what's going on, the artery is becoming blocked because of platelets that have accumulated, which is what comprises a clot. Aspirin inhibits platelets from aggregating, from forming a clot. So you want to stop that process, and aspirin stops the clot accumulating process. It may not be perfect, but it stops it. So aspirin is the first thing that you want to use. Remember to ask about aspirin allergies, and if they don't have the allergy, then aspirin is 81 milligrams, and you want to chew 2 to 4 pills. I don't know why you just chew two. I always say, 4 pills chewed. They should not be enteric-coated, but somebody asked me today, well, what if it is enteric-coated? And I said, well, if that's all you got, well, you chew them. I said, chewable aspirin tastes better than enteric-coated, but you know what? A little bad taste compared to stopping a heart attack. I think we can deal with the trade-off there. There are some other what we call contraindications that to think about. Let me see. And so once again, if you're allergic to aspirin, if you're actively bleeding, I mean, if you have an active ulcer, if you've had a hemorrhagic stroke, if you've had bleeding in the brain, particularly if it's recent, we're not going to give that person aspirin. It becomes complicated, but you have to do the best thing you can. The one that says children with cold and flu-like symptoms, kids don't come in with heart attacks, but are people familiar with what that problem is when kids have colds and flus and fevers and they give aspirin? So that's called Ray's syndrome, and that can be disastrous. It can cause CNS, severe central nervous system damage. And it's just something that's why we tell you to give kids Tylenol and not aspirin if they have a cold or if they have a fever. And then nitroglycerin. Nitroglycerin, you can either give a spray or you give the pills under the tongue. The protocol is you can give the spray up to 3 times every 5 minutes until there's pain relief. And if there's no pain relief, then, well, you can give them morphine to get rid of the pain, but pretty much, the protocols call for up to three times with sublingual or spray nitroglycerin. So how does nitroglycerin work? Nitroglycerin works because it relaxes smooth muscle, and arteries have muscle in them. And so arteries can narrow because the muscle contracts and the muscle gets bigger, so the channel gets smaller, kind of like when you flex your biceps muscle gets bigger. So the muscle in the artery wall gets thicker and then the opening gets narrower. So if you give nitroglycerin, the muscle relaxes and that opening gets wider. So that's why when people are having chest discomfort, this will alleviate the chest discomfort because you've just improved the ability of the artery to supply the heart muscle. So that's the way nitroglycerin works. Some of the things that you should not give nitroglycerin for, and this is another reason why you give aspirin first, because you don't have to check a blood pressure when you're giving aspirin. Do not give nitroglycerin unless you have a blood pressure, because you can really cause problems. If their blood pressure is 90 and you give them nitroglycerin, all of a sudden you've taken them from a borderline situation to a situation where their blood pressure may drop to 70 and then they're in shock. And a heart attack with shock, the mortality rate goes way up. Head injury, part of the reason for that is because, as I said, nitroglycerin opens up blood vessels. Well, if you've got a bleeding blood vessel and you open up the blood supply, the bleeding will increase. Maximum dose, the three doses, not necessarily in the past hour, but just basically the 3 doses that you've given. And then once again, the use of medications for erectile dysfunction. What happens is if you mix these with nitroglycerin, you will probably go into shock because you have not only relaxed their smooth muscle, you have um, erectile dysfunction medications open up the blood vessels in a different way. So you get what's called synergy, meaning you've got a blood vessel opening with two separate actions, and your blood pressure will drop precipitously, putting people into shock. Once again, uh, uh, pretty much giving you some more specific figures. If the person's normotensive, bringing them down to by 10%, drop of 30%. These are guidelines, maybe a little bit complicated, a little bit detail oriented, but pretty much if their blood pressure is below 90 or 100, you're not giving them nitroglycerin. The benefit that you're not going to get any benefit, and you're going to destabilize the patient. And this is basically the state of Connecticut OEMS protocols, which probably a lot of us are basing our medical protocols for our ski patrols. So it's important and say, okay, well, why are we doing this? Well, this is pretty much the level of EMT, what EMT interventions, which is basically aspirin, nitroglycerin, and oxygen. Those are the three things that you can do on the mountain depending upon your mountain's protocol. And some people may say, well, we don't feel comfortable giving nitroglycerin because we don't want to put them into shock. And my wife says, if you don't have an IV in the person and you drop their blood pressure, you can't raise their blood pressure by giving them because you can't give them IV fluids. And if somebody's been skiing all day and they're dehydrated, she's right. It could precipitously lower their blood pressure. So you want to make sure that these people, you have their blood pressure, they're lying down, and I would say they're considerably over 100 millimeters of mercury, because you don't want to drop it below 90.
Steve, I'm just going to point out too, what I always ask is whether the person has ever taken nitro before. So
Thank you.
Their first time, yeah, that's a different situation.
No, and that's a great point to bring out. I'm just going to skip through these because these are paramedic levels. They talk about giving IV or intraosseous nitroglycerin in a drip form. They talk about giving fentanyl and morphine. One of the reasons why it's good to relieve pain is because pain creates emotional distress. Pain creates upset. And so emotionally distressed and people in pain, what happens to the utilization of their oxygen by heart muscle? So if you can bring down the distress, you can at least alleviate some of the strain on the heart muscle. And another aspect is, all right, so this is some of the things that you should check. Obviously, the blood pressure, medications taken, particularly erectile dysfunction medication. And as part of our OEC training, we always say name on prescription, check the expiration date. And also, if the person has nitroglycerin, how many nitroglycerin pills have they taken since the onset of the discomfort?
And I'm going to jump in one more time. With those erectile dysfunction drugs, people need to recognize that women also take those. You mentioned pulmonary hypertension, but of course we have a number of our colleagues out west, and they are using these drugs as well for altitude illness. So there's a couple
Oh, thank you.
Yeah,
Thank
that
you.
both males and females can be taking them, so it is worth asking.
And I'm going to tell you one other one, and this is just like nitroglycerin can also alleviate another kind of chest discomfort. So if somebody says, oh, I got better with chest discomfort, people who have what's called esophageal reflux or GERD or hiatal hernias, they can, because of the smooth muscle relaxing properties of nitro, sometimes these people get relief. I'm not saying, oh, it's gas and, you got better with nitro, it's not your heart. But I am going to say that there's all kinds of things where the patient doesn't follow the textbook. And that's why I tell people that I don't want to present an AI algorithm. I want to present you with an approach. I want to present you with a systematic approach and a way to think with both the left brain and the right brain. I'm not going to go into this. But basically, this is a woman who's having acute onset of right-sided chest pain. It's tingling and burning. It's to the right shoulder and the jaw. It's only 2 to 3 out of 10. It's not that bad. Came and went all day, but it's steady over the past hour. Once again, women will have funny symptoms, and it's your level of suspicion. It's your assessing if this person has risk factors. And here, this person has type 2 diabetes. Diabetes also has these unusual symptoms, and they have high cholesterol, smoking, mother had bypass surgery at 48. So there was a lot of things here that say, okay, risk factors, unusual symptoms, but risk factors. So your suspicion level is what can save a life. They say that women have a higher death rate than men because of heart attacks, and part of it is delay to diagnosis. So it doesn't mean you have to hit the alarm bell for everybody who has a little bit of discomfort, but women have heart disease. Women develop plaque. Women have heart attacks. And if they're not feeling well and if they have chest pain, don't just say, oh, we're going to brush it off. You call a doctor, you call 911. What's the worst thing that's going to happen? You get an EKG. I don't think that's life-threatening. So the message is have a high level of suspicion, and you can be the one to save a life by calling 911. So here it is, typical picture everybody sees, but this is the atypical picture of, oh my God, mom is having a toothache. Let's call the dentist and realize that that may be a heart attack. So is oxygen indicated? So the official guidelines, and we are taught this in OEC, is any oxygen concentration below 94%, they should be placed on oxygen. I say that it's not a bad idea, although I'm going outside of guidelines to say if you see somebody who's nervous and if you give them a little oxygen, you see them relax because they have more air flowing past their face and they find it relaxing. You know what? You're not doing harm for the ambulance ride to do that. But I am saying that it's not protocol. So if somebody was to do that on a test, say 94%. So what do we do when we get this person to a PCI hospital? PCI is not just taking a heart catheterization. PCI stands for percutaneous, meaning you're going through the skin, coronary, meaning the coronary artery, intervention, meaning we're doing something inside. We're not just taking the pictures. We call that an angiogram. This is actually doing something to the artery. So what do we do to the artery? So what we do is we're passing on the left, we're passing an uninflated balloon with some mesh on top of it, and we cross the artery, which has maybe partially opened. Sometimes we may have to do a little pushing through with the very, what you can see is that silver wire is called the guide wire, and that can gently push through the artery, and then you slide the balloon over it like a monorail. So you cross the plaque, then you inflate the balloon, it pushes the stent, which is that wire mesh, against the artery, and then you pull out that balloon, and then you have what's called the deployed stent, which is the scaffold that's going to hold that artery open. And what it's doing, it's not taking the plaque out, but it's mushing the plaque, which is kind of the consistency of silly putty in a way, and it restores the blood flow. So here is a picture. in the middle of the screen, you see um, uh, a branching network. And if you can appreciate that on the left side, there's an area that looks kind of lighter, and on the right side, it looks darker. It means that we've opened up that artery. I think this, oh, no, it's not there. So that's what the stent does. It restores the supply. Depending upon how quickly that artery gets open is how much damage to the heart muscle is done. So I think we've come to the end of what I have to say, and you've been a great audience. And so one of the messages, just a word of caution. And I've enjoyed doing this. I hope you found this enjoyable yourselves. And it's been my pleasure to talk.
This has been awesome, Steve. I do see a couple of comments in the chat regarding people who have COPD who have naturally low oxygen levels, as well as those who may be at altitude, right, where their oxygen status, their pulse ox is low due to the altitude.
Right. COPD is a funny thing because in certain people, they rely upon their low oxygen level to stimulate themselves to breathe. And if you shut off what's called the hypoxic drive, their carbon dioxide levels can get high, and that can get them into trouble. But the average COPD person who doesn't have severe COPD, it's not harmful to get their levels up there. And if you need to give them a respiratory treatment to help that, if they have their own, that's great. But you do the best you can. I don't have a hard and fast rule on that. And for altitude people, because of the lower partial pressure of oxygen, it may be harder to get them to 94. Well, you just get them up from where they are. Try and raise it. If they're at 85, try and get them to 90. At least bring it up with oxygen. And you do the best you can.
So there's another question regarding the stents, and are they coated with any type of drug to dissolve the plaque, is the question.
Great question. It's not, they are coated. One of the things that used to be a problem when they first started stents is when they open the stents, it injures the delicate inner lining of the artery. And so you get this reactive growth of the inner layer of the artery, and it would grow so much that it would block off the channel. We would call that restenosis. So what they literally did was they tried to find the magic drug that would stop these cells from dividing. And so literally what they have now coating them is chemotherapy. I mean, micro amounts, but they're basically chemotherapy drugs that stop the division of these cells. That's an excellent question, but it doesn't dissolve plaque. And one of the things they've just are working with now is dissolvable stents, meaning that they don't become permanently part of the artery. You don't want them to dissolve too quickly because you don't want the artery to collapse without being buttressed. But it's something that some people don't like the idea of something metal staying in their body.
Another question is, you mentioned earlier about assessing a patient, asking them to sit up and lay down, etc. Do we want to stress a potential heart patient, is the question.
It's sitting up and lying down, it's minimal activity. I'm not asking this person to sit up and do an exercise. You help them. You can help them sit up. it's minimal activity. You're not, and I understand the question. Obviously, if this person is in severe distress and they're short of breath at rest, you don't want to manipulate them. But if somebody is there saying, I'm hurting, ouch, and my chest hurts, it will help eliminate a diagnosis or um, include a diagnosis that we'll talk about next time.
A person named Tim asked about restating the women taking erectile drugs, and what I mentioned was that women take erectile dysfunction drugs. They are also used for treatment of pulmonary hypertension, which is a disorder that anyone can have actually, and so these drugs work for that. They are also part of the treatment algorithm for altitude illness in certain cases. So women may have altitude illness as well. So the idea is make sure that you're assessing both men and women for whether or not they take erectile dysfunction drugs. And then there's also a question, Steve, regarding curious about the diameter or size of the coronary artery.
Yes. The even I'm not 100% sure, but generally we talk about a stent being about 5 millimeters by 25 by 15 or 25 millimeters. So 5 millimeters is roughly about an inch, because a centimeter is 2 inches, and it's an inch by about 2 or 3 or 4 inches long, and that's what the stents are. So it's generally 5 millimeters, but way up at the beginning of the arteries, it could be 6 or 7 millimeters, and way down at the end of the artery, because the arteries taper, it could be 1 millimeter. So if you're going to put a stent in, there's a real art, and for the interventionalist to know matching up the size of the artery to the stent, because if you put in the wrong size, you can actually you can create a tear. And if you don't put in a large enough one, you're not alleviating the obstruction.
Okay, so I'm seeing two more questions. One
Yeah.
is, if a person is having a cardiac incident, would there be oxygen saturation decrease?
Not necessarily, but if someone is when you have the heart and it can't pump, sometimes people go into what's called congestive heart failure. And congestive heart failures, one of the things that's prominent is that these people develop fluid in their lungs, meaning that the heart can't handle all the blood that's coming from the lungs to the heart. So the pressure of the fluid in the lungs builds up, and it's literally like a sponge. And like a sponge, there's those little air pockets. Well, those air pockets are normally where your oxygenation occurs. And if you get water in them, then the oxygen level goes down. So that's generally the one time, but it's another really good question. But generally, someone having a heart attack, it generally, unless they're going into heart failure, their oxygen level will probably not go down. One of the other times where the oxygen level might go down is if somebody can't take deep breaths because it hurts to breathe. That's different. And that's because the lungs can't expand and they partially collapse, and that's called atelectasis. But no, but in the typical cardiac heart attack patient, you're not going to be dealing with what's called hypoxia. But if you do, indications are clear. Get it over 94%.
And the last question, common names of the erectile dysfunction drugs for women. And to my knowledge, they're still the same names as like
Yeah.
Viagra and Cialis and
Levitra.
Levitra. Yeah.
So it's tadalafil, sildenafil, and I forgot the last one. But tadalafil, sildenafil, and then Cialis, Viagra, and Levitra.
I think that covers the questions that I see. Um, I'm seeing lots of excellent presentation and thank you, and lots of people wanting to know where it's being recorded, and it's going to be on the Bear Creek YouTube channel. So thank you again. Very, very great presentation, and it looks like it was well appreciated.
I really enjoyed giving this, and I look forward to, oh, well, the questions we already asked. And I look forward to another one. And if people are interested, I'm going to do another session on July 28th. Is that what we agreed on?
That's
So
it.
Eric, thank you. Eric, the way Eric and I got hooked up is Eric is part of the Patrol Stress Awareness team. And is that correct, Eric? Am I right?
Yep. No,
And
you are
so
absolutely correct.
Eric is more integral, but I was part of it, and Eric got me interested in some of the work that was being done with continuing education with Bear Creek, and I hope this collaboration continues.
Yeah, and thank you, Steve, and I'm glad you're able to do it. And for those who are interested in part two of this lecture, I will be sending out an email with a link shortly once I get everything set up. So please keep keep an eye out for that email. Always, thank you for coming out, and I hope you guys have a great rest of the week.
Thank you. This was
Absolutely.
great.